Hi, everyone. It's Dr. José Pereira here, and I'm the Scientific Officer of Pallium Canada, and welcome to this, the third episode of the Pallium Palliative Care Journal Watch. It's a journal watch that we do every 2 months, and during each one of them, we invite some panelists. You might see some well-known faces as we do the series. And the series are hosted by Leonie Herx, who will introduce herself shortly, and myself. The Journal Watch is supported by a grant from Health Canada. The whole project is looking at supporting communities of practice, and it's a 5-year national initiative. So what is the Journal Watch? It's a regular series of webinars with accompanying podcasts where teams from the Division of Palliative Care at McMaster University and the Division of Palliative Care at Queen's University peer review and rather look for papers in various journals and then bring them to the webinar if we think that they are very relevant to our practices. We do it because it's becoming increasingly difficult to stay up to speed with all the new papers and studies coming out. And so we do know that a lot of the folks who've done LEAP courses before would like to maintain some contact with the LEAP program and update their expertise and knowledge around it. So this offers an opportunity to do so. And we also know that there are a lot of LEAP facilitators across the country who would love to have access to the journals, but don't. And so this is one way of giving them access to the journals. The Journal Watch is for clinicians, for managers, educators, and policymakers across the country. As I said, we have teams at the 2 divisions that monitor different journals and then bring to the attention of an editing committee papers that are of interest, and then we select the top 4 or the top 5. Today we have 4. We also list what we call the honorable mentions. So those are papers that we think are really worth looking at, and we provide links to at least the abstracts of those papers so you can have a look at them. As I said, there's accompanying podcasts, so please do go to the Pallium website, specifically the page on the Journal Watch program, and you'll see podcasts. I know there's the one for the first one was already on, and we may be seeing the second one very soon as well. And then in a few weeks' time, you'll see this one posted. The sessions are accredited by both the College of Family Physicians of Canada and also the Royal College of Physicians and Surgeons for continuing medical education certificates. So what do we expect today? As I said, we will be looking at 4 papers. They're short summaries. And please do participate. Feel free to ask any questions to the panel around each of those papers, and please do use the Q&A function of the Zoom session. If you've got other comments, you may also post them in the chat box area of the webinar. A disclaimer: Journal Watch is not a journal club, so we do not go into in-depth critical appraisals of each of the articles. We just bring to your attention areas that we thought are interesting. Obviously, as a group, we do try and select papers that we think are robust in terms of their methods. Next, please. So by way of introductions, as I said, I'm the Scientific Officer for Pallium Canada. I'm also Professor and Director of the Division of Palliative Care and Department of Family Medicine at McMaster University in Hamilton. And I'll turn over to Leonie to introduce herself.
Hi, everyone. It's Leonie Herx. I'm the Division Chair and Associate Professor in the Division of Palliative Medicine, Department of Medicine at Queen's University. Great to be here.
Lisa, all the way from the East Coast.
Absolutely. Thank you for inviting me. I'm Lisa Weatherby. I'm the Provincial Practice Lead for Palliative Care here in Nova Scotia with the Interprofessional Practice and Learning Portfolio. So I'm, just as I said, absolutely thrilled to be part of this.
Jordan.
Hi, my name is Dr. Jordan Lafreniere. I'm one of the palliative physicians working at St. Peter's Hospital here in Hamilton, and I'm associated with the Division of Palliative Care here at McMaster. Thanks for having me today.
Great. Some quick disclosures. Pallium Canada is not-for-profit and has been over the years funded largely by Health Canada through contribution agreements. I've shown on the slide which years we receive those contributions for. And there's also been some funding from foundations such as the Li Ka-shing Foundation, from the, there's an area there, it's not OMA, it's actually Canadian Medical Association, CMA, Patrick Gillen Family Trust, and Beringer Ingelheim, who have helped us disseminate the Li Blung, but have had no influence whatsoever in the development of those courses. And we do have partnerships with provincial bodies and also some federal organizations. And a lot of the work is also supported by revenues from the LEAP course registration, fees and licenses, and the sales of the Pallium Pocketbook. This particular program, the ECHO program, has received financial support from Health Canada in the form of a contribution agreement program. In terms of disclosures, I do receive a stipend as scientific officer from Pallium Canada, and my co-hosts and colleagues today have no conflicts to declare. And just so you know that the scientific planning committee for this has got complete independent control over the content, and also Pallium in general has complete independent control over its programs, including the LEAP program. So today's featured articles. So we have a variety of articles that we think will appeal to a broad audience. We have 2 articles related to advanced care planning and goals of care discussions. One I think will be particularly interesting discussion. We have one related to the opioid conversions when we're doing opioid switching or opioid rotations. And then there's one on artificial hydration. And a more recent paper, in fact, when I was looking at it, I realized that it's been a while since we've seen a really good study on that topic. So really keen to introduce that one to you today. So with that, then we'll go to the first one. And so the task is fallen on me to do the first one. So the first paper is a Dutch paper. It was a study that was undertaken in the city of Nijmegen in the Netherlands by Tros and colleagues. And it's entitled General Practitioners' Evaluations of Optimal Timing to Initiate Advanced Care Planning for Patients with Cancer, Organ Failure, or Multi-Morbidity, a health records survey study. And that was published in Palliative Medicine just a few weeks ago. Now, the background to this is that general practitioners, and just remember that in many of the European countries, family physicians are referred to as general practitioners. So that's where the word GPs come from. So GPs find it difficult to determine the right time to initiate advanced care planning. And that's both in cancer patients, but especially so in patients with non-cancer illnesses such as advanced heart disease, lung disease, kidney diseases, and neurological diseases, among others. And so the appropriate timing of advanced care planning is a question that's often asked and very important. When do you initiate these discussions? Because if you do them too early, you could lead to plans not reflecting what the patient's wishes are. If you wait for too long and do it too late, then invariably you end up in a crisis situation, having to make decisions in a crisis, and which often or sometimes don't go very well. So the objectives of the study was to determine what GPs consider the optimal advanced care planning timing and important clinical indicators to initiate it. So in other words, what do the GPs use as their flags, as it were, to activate an advanced care planning discussion? And then they asked the question, do the timing differ between 3 illness trajectory groups? So they chose, this is work that we know from the work of Joanne Lynn and Scott Murray in Scotland, where they've mapped out these illness trajectories, and there have been other studies to confirm that these trajectories do actually exist. So the one is the cancer trajectory, which is the more predictable one, with decline and then more rapid decline in the last weeks or months of life. The other one is the advanced organ disease, so advanced heart disease, lung disease, renal disease, where you've got this gradual decline interspersed with these episodes, these crises, complications. And then there's the frailty or comorbidity trajectory, which is typified by dementia. So it's gradual decline over many months and years. So they found 90 real life cases. So they went to the charts, and they went to the charts of groups of family medicine practices or GP practices in that part of the world. And they identified 90 real cases, so the charts of real cases. They anonymized those charts, and they removed any information related to advanced care planning so as not to cue the participants who are the GPs. So they had these 90 charts, as it were, and they then recruited 83 GPs. Most of them were GPs from what's called a practice-based research network. So these are practices that collaborate in doing primary care research. And then they also asked them by a snowball method, please let us know if you've got colleagues who you think would be interested in the study. And so they recruited 83 GPs, and each of those GPs were then asked to review three charts. One chart that was reflective of the cancer illness trajectory, one chart that reflected organ failure, and the other one that reflected the frailty, comorbidity trajectory. So what were the results? Well, they found that there were significant differences among the GPs and also across the disease groups, that is the cancer versus organ failure versus multi-morbidity. So the median, and I say median because there's quite a range, and in fact, I have provided on the slide some of the interquartile ranges, but there was significant variation between these diseases. So the GPs said overall that for cancer, they would have initiated advanced care planning about 87 days before death, and the interquartile range was 302. For organ failure, they would have initiated ACP discussions at about 266 days before death. And for the multi-morbidity, it was about 290 days before death. Those were the medians. Okay, so remember, they're looking through the chart, and then they're going back and they say, oh, at this point, I would have initiated advanced care planning discussion. And then the researchers looked at how long was that before death, right? So obviously in the real life, we don't know when death is going to occur. You can't say, I'm going to be doing 290 days beforehand. Now, what was interesting was the most frequent reasons for initiating advanced care planning. So for cancer, it was receiving a diagnosis. So when people received a diagnosis or there was a indication of progression of the disease, that was the prompt for the GPs to initiate ACP discussions. The other one was no curative treatment options available. The other was poor prognosis. And then there was expression of patients. And by expression of patients, they meant when patients said, I would like to speak about advanced care plans. In organ failure, the most common prompts for them to say, okay, at this point, I'm going to be doing advanced care planning was after a period of illness, so a decompensation, so compensated heart failure or lung disease, for example. Appropriate setting, a quiet place, and say, okay, we're going to have a discussion about this. Again, expressions of patients. For multi-morbidity, age was the big prompt, followed by patients expressing it, and then acute symptoms occurring. So why is this article important? Well, I think what it shows is the optimal timing to initiate advanced care planning could be seen as a window of opportunity if you look at those interquartile ranges, and that the timing needs to be tailored to individual patients. And I'm going to ask in the discussion, what about those patients who don't express a wish to have these discussions? What do we do then? The strengths of the paper, I thought, was it's a unique study and design, uses real life examples because these were actual real life charts that had been anonymized. The limitations obviously does not depict real life. 290 days before death, we don't know if this is the 290th day before death. So I take that into consideration. And then interestingly, in this group of GPs, about 20% of them actually had an additional extra interest in palliative care and did a lot more palliative care. Next. So for the discussion, let's open up to the panel. And as I said, one of the interesting things I found in this paper was, and maybe this is an inference I made, it might be incorrect, but in reading the paper, I got the sense that there are quite a few GPs who would say they would wait for the patients to initiate the discussion. So what do we do if patients don't initiate the discussion? Thoughts on the paper and on that particular question to get started?
So I can jump in, and my most recent experience has been with some patient family advisors, and they sit on our network here in Nova Scotia. And I keep hearing from them that they didn't know what to ask. They didn't know what the questions are. So I feel pretty strong that the responsibility comes back to us as healthcare providers. So when I think of all of the tools we promote and LEAP, the surprise question, the SPICT tool, I think that, or I would hope, if this study, and Leonie, you said a couple weeks ago about needing a Canadian kind of wide study to say, I would hope of all of our, early approach and introducing palliative care kind of early in that illness trajectory. Hopefully our introduction of advanced care planning would come a lot sooner than this study did, or maybe that's my own hope.
Yeah, I'll jump in, Lisa. I agree. I think we need to have standardized ways that we think about this so that it's not just left to an individual clinician's practice and individual patient's preference, because then we're going to miss people. So I think if we have standardized ways, like some of these tools you're referring to, that we identify people who have perhaps unmet palliative care needs or palliative care needs, that then provides an opportunity for us to do what we're doing through our a multi-site grant that we're part of. Is an ACP readiness questionnaire. So there is a tool that you can use, a very brief, short 4-item questionnaire that lets people know like where they're at in terms of their readiness for the conversation. It would be great if that could be like integrated into providing a palliative approach. And then of course, what do you do if they're not ready for a conversation, but they really need one? So I guess, if they're at high risk, say if we had national patient reported outcome data sets like phase of illness, which I hope will be moving forward in Canada. If you see someone is on an illness trajectory where they're deteriorating or transitioning, then that's another prompt, right? To say, we need to have these conversations, even if perhaps they're not ready for them. So those are just some of my initial thoughts.
Actually, in this study, Leonie, they did identify some of that as some of those prompts as well. So changes in the health status, complications occurring, acute disease. So fortunately, I saw that appearing in the study.
And so I'll jump in as well. And, I think what they also mentioned in the study, which I think is very interesting, is that I don't think there is any one right time to kind of introduce these periods. And as it's saying, I think there are these windows that give you an opportunity to, and you probably have multiple of those windows throughout a patient's trajectory. So I think it's just recognizing those and taking advantage of those to, again, even assess somebody's readiness to have that conversation, and just, I think, give family physicians agency to have that, which, can sometimes be a little difficult in a busy family medicine clinic. But just, again, I think promoting that there isn't going to be any strict guidelines in terms of this date, this date, this date, and just to, again, have people have a bit more agency around that.
I think the standardized tools, though, help trigger those, right? So you can build them into EMRs, for example, right? So that would be ideal, so that just like health screening based on age, that prompts the family physician to do this. Or it could prompt, say, the nurse in a family physician's clinic to do an ESAS and to do a phase of illness. That's then documented in the chart, and then that in itself would trigger then the next conversation, or perhaps a specialist consultation for palliative care if symptoms are certainly severe. So, but the same thing with ACP, I think, would be very helpful.
Then I think the next part may be making sure that healthcare providers have the tools to be able to comfortably have the discussion. So I often think back, José, to when we introduced the wish, worry, wonder. Yeah. So by putting some of that discussion back, it becomes a little less fear around bringing that up with some of these individuals, regardless of what their presenting illness is.
Very much so. I can't help but say something a little bit about the surprise question, because people often say it's not useful because it's a poor prognosticating tool, but it was never developed to be a prognosticating tool. It was developed as a way of changing culture, to move the culture of palliative care being only at the very end of life to much earlier. Good. So with that, then let's go on to the second article, and Jordan.
Thanks, Jose. So the article that I'm presenting today is an article by Constantino titled "Variability Among Online Opioid Conversion Calculators Performing Common Palliative Care Conversions." So, doing opioid rotations is very common in palliative care. We do it all the time for a host of different reasons, whether or not that's tolerance, whether or not that's poor pain control, worsening side effects, opioid-induced neurotoxicity. It's done quite a bit. And one of the tools that has been starting to pop up is a lot of these online opioid conversion calculators. And so the purpose of this study is to really just describe and kind of really just see, are all these calculators the same? Do they work well? Does one work better than the other? And are these accurate tools that we can use when we're thinking about doing opioid rotations? So essentially what they did was there's a online palliative care Masters of Science program that's run out of, I believe, the University of Baltimore. So they recruited about 58 adult learners, which were primarily practicing physicians, nurses, and pharmacists. And essentially they kind of asked them to do an exercise, which was choose any 3 online opioid calculators that they wanted to. And they gave 3 separate case scenarios and asked them to use those tools in order to come to a conclusion or come to a certain conversion. And then they plotted those and referred those and compared those to the kind of control group, which was essentially 3 pharmacists coming together doing a manual opioid calculator. So that was kind of taken as the the standard of care type of thing. So in terms of the results, what they found was there was actually substantial variability leading to a very wide range of outputs, which is fairly concerning, because I think there is a lot of harms both with either underdosing and over treating pain. So if you're underdosing, you're leaving somebody in quite significant amounts of pain for potentially a long period of time, depending on your care setting. And certainly, again, if you're over treating, then you're running into, certainly sedation, opioid-induced neurotoxicity, delirium, all the side effects that, even respiratory depression and death, which can obviously very much harm patients. And I'll talk a little bit more about the results later, but they also found that most of the participants that went through this and actually did all these, used a lot of these online opioid conversion calculators, they found that 75% of people had a very negative sentiment towards them. About 20% were neutral, and only maybe 3% actually found that they would use them. And essentially, why is this article important? I think it really highlights the inconsistencies, potential dangers, and significant limitations when it comes to using online opioid conversion calculators. And in the article, they go into why this is the case. And it really comes down to what does it really take to do an opioid rotation? What are the processes? What are the steps? And they really kind of break that down into kind of 5 main steps. One of them is pain assessment, which is a lot of where our clinical expertise comes in, as a palliative care and as primary care physicians. So, and again, as Dr. Alan Taniguchi would say, the key to good pain management is good pain assessment. And that, isn't something that can be done by an opioid conversion calculator. What's the severity of their pain? What's the etiology of their pain? They really can't do that. Number 2 is calculating a total daily dose. Well, yeah, a calculator can do that. Number 3 is actually, converting from, that particular opioid to a different one. And, even so, you'd think, okay, a calculator, that's what it's meant for. That's what it can do as well. But, the tricky thing is, I think is that there's a lot of complexities when it comes to opioid conversion. And it's not because of the math. It's 3rd grade math. It's, I think, the fact that there's a wide range of opioid conversion factors, and that really significantly vary across really where you look, when you look, what resources you look, and, your geographic origin. And then, even thirdly is, Some of these calculators don't even tell you what the conversion factor is. They kind of really keep that hidden. And some of them automatically account for cross tolerance, which is often done when we rotate opioids, and that can be as much as 25 to 50%. Which, you know, again, if you don't account for that when you're doing the calculator, or maybe you do, and then you're adding an extra 50%, you can get these wide ranges. You know, the fourth thing that they mentioned in terms of an opioid conversion is taking into patient-specific factors, which again, a calculator is not going to do. So that's taking in age, renal function, hepatic function. Do they have subcutaneous fat deposits? You know, all these things that we also look at. And then number 5, and almost most important, is also monitoring. So, you know, how are they? Are they responding? Do they have pain? Are they using breakthrough? Are they sedated? Are they eating? You know, all these things, you know, require a lot of breakthrough. So again, really, when you're converting an opioid, it's a 5 steps that at best an opioid calculator can really only do 2. So and I think that those were kind of a lot of the things that the article is really highlighting. You know, some of the strengths, I think, of the study were that, you know, they really did try to mimic kind of real world conditions. So they did ask, you know, use any calculator they want. Like if you were going to Google a calculator, you know, what would it be? So they weren't prescribing calculators necessarily, and they were trying to keep those, the case scenarios as real world, using conversions that, you know, we as palliative care doctors would do every day. You know, some of the limitations are, you know, again, it's an online Masters of Science course. With varying levels of experience, although most people, you know, we're practicing in the palliative and hospice setting. And then again, it's just in the US. So then there's just kind of a geographical difference. So I apologize for all the podcast listeners, but for those on the webinar, you know, this kind of slide, I think, really sums it up. So you can really see that, you know, again, in scenario 1, it was converting transdermal fentanyl to long-acting morphine, and there was a range of from anywhere to 60 to 3,125 milligrams. For the second scenario, is IV hydromorphone to long-acting morphine, and there's a range of 90 to over 8,000 oral milligrams. And for a conversion from morphine to methadone, it was a range from 7.5 to 120. So these are huge wide ranges. There was vast clinical significance between the calculators, and kind of the gold standard pharmacist manual opioid conversion kind of answers that they came up with. So I think this really highlighted really the fact that, you know, for me personally, I wouldn't use these calculators in my practice. And certainly when I'm doing my teaching to residents, it's not a resource that I would use. And, you know, even when you're using a calculator, a lot of the calculators will say, you know, please take this into account with clinical judgment and compare this with your manual opioid conversions, which seems silly to me because the whole reason to use these calculators is to increase efficiency. But if what you're outputting is so varied and, you know, to be honest, you know, with, you know, oceans worth of salt, then, you know, kind of what's really the use.
Wow, Jordan, what a comprehensive coverage of the article. When I totally read the article, I went and needed to reread the line, conversions could vary by 100 to 242%. So I got it wrong, read it again. I've never used a calculator because I love math. But when we would deliver our LEAP sessions, often people were asking, calculator. So never had I, until this article, realized the risks inherent with the use of the calculator. What we do promote when we talk about education is we always talk about phoning a friend. So we think, who is your friendly pharmacist in community, who is the palliative care doc or family physician you work with, and doing that 5-step process every time. So doing the assessment, and then we always do the calculations independently, and then figure out, okay, did we take into account the 25% decrease? Did we think about all of the factors that you mentioned? So for me, this article was really applicable real time.
Jordan, you know, and Lisa, I think just to be clear for the listeners, when you say don't use calculators, you are saying don't use the opioid conversion software calculators, not a general calculator, because I do have to use calculators occasionally, but I do not use them.
So do I, Jose. So do I.
Exactly. I was going to say Lisa's got one step ahead of me on this one. My maths is not that fantastic, no, but it's specifically the opioid conversion software. The study really resonated with me because just a few months ago, I was teaching a master's course as well in palliative care in Europe. And there were about 30 people in the classroom and came to a calculation. They pulled out their phones and went to these different apps, and we got all these different results. So I really think it's an important study. Interestingly, when I read the paper, the authors suggest that, well, they try and explain why there's so much variation. And one of the reasons they explain is because a lot of the tables, we tend to refer to the daily morphine equivalent dose, or MED. So when you're doing a switch, for example, from fentanyl to, I don't know, to methadone, we often go via the morphine route by calculating the morphine equivalent daily dose. And we do know from studies, I remember I did a study once with Peter Lawler and Eduardo Bruera. We published a very large, we did a very, very large review, systematic review of opioid equianalgesic dose ratios. And we published that in the Journal of Pain and Symptom Management in 2001. So that's 21 years ago. And we already noticed, even just with the paper tables, there was a lot of variation because of that morphine equivalent daily dose, because there's such range amongst individuals. You know, we often say morphine to hydromorphone is an equianalgesic dose ratio of 5:1, but actually varies a lot from 3 to 7 or 8:1. But the one thing that I thought that the paper did not highlight was one of the other reasons I think that we see this variation relates to not indicating, and you refer to that, Jordan, not indicating what ratios they're using, because there's a difference between acute pain management and chronic pain management. In the acute pain management, so someone who's hurt themselves on a sports field comes into an emergency room, needs an opioid for analgesia, the equianalgesic dose ratio of morphine to hydromorphone is 7:1, but approximately, right? So the ratios, and we found that back in 2001, differ whether you're using studies that come from acute pain labs or versus chronic pain management. So I just thought, you know, that was an interesting one that wasn't highlighted as a possible cause for this confusion.
I think Jordan, did the article end with, and I thought it was a recommendation that if facilities feel they need a calculator, that it be credited and validated by that facility, which I thought was a good idea. So that if we have people who are needing and feeling they need that extra, at least we're clear about what is the validity of that tool.
And I think they do mention that, you know, if this is a tool that you do want to use, just to make sure that, you know, within your healthcare setting or within your network, just to make sure everybody, you know, one picks a calculator that is, you know, has been vetted by, you know, a physician, a pharmacist, you know, a team that has, you know, transparency in regards to, you know, the use of conversion factors, what those conversion factors are, you know, automatic cross tolerance inclusion, you know, all these types of things, and to really get on the same page with one, if that is something that you're going to do. Because the, you know, the hard thing is when you have, you know, and I think they, in the study, I think they had almost like 80 to 100 different opioid calculators that different people found. So there's a lot of these out there, and you know, it's hard if you're really just, you know, very early or you're a learner to know which one is the one to use.
I really want to highlight two very interesting comments here. One was made by Paul McIntyre out in Nova Scotia, I think it was, and the other one, Jesse Solomon, Jordan's colleague here in Hamilton. So Paul writes, I found this blog entry provocative, and there's a link there in the Q&A box to that blog. He found it provocative, but difficult to wrap around, not referring to online calculators, but equianalgesic tables at all. Opioid equianalgesic tables are broken. Drew Rosiel proposing we do away with equianalgesic tables as a tool to inform clinical decisions about opioid rotations and conversions. What do people think about that? my reaction is you got to start somewhere. And without some guidance, I think it could cause more damage. But we need to understand the limitations of these tables. Any other thoughts?
And so I'll say, you know, just going through the study and even just on the graph that you could see there, there was obviously some intervariability between the pharmacists as well, which, you know, could vary as much as, you know, 50, I think it's 25 to 50%. So the inter-pharmacy variability was there because it always will be. And I think if you took 100 palliative care docs and then asked them to do the same thing, I think you wouldn't get 100 of the same answers either way doing manual opioid rotation. So again, like Jose said, I think you have to start somewhere. And Jesse, you know, just like you're saying, you know, you just can't walk away from it and, you know, call it a day. I think you know, that fifth piece in terms of kind of doing opioid rotation, which is the monitoring and the kind of the dose adjusting from there is, you know, is paramount and, you know, is arguably one of the most important parts of doing an opioid rotation.
Very good. And just to wrap up the discussion on that one, I just want to share Jesse Solomon's comment. I wish I could have seen the pharmacist's intervariability. There are so many conversion tables that it's likely they all come up with different conversions. During my fellowship, I was using Lynn McPherson's Demystifying Opioid Calculations, which was a new publication, and her conversion table did differ from my attendance. It underscores the importance of making a calculation, but then not walking away from the patient. Absolutely. So I thought that's a very good place to end the discussion, and that is, remember the clinical assessment and the clinical examination and the ongoing assessment, particularly when we do switches, because you can either hit the nail on the head and get the dose right, or it could end up with an overdosing or an underdosing. So with that, I'll go on to Article 3, which I think I've been tasked at doing, and that article is by Ho and colleagues, Canadian colleagues. They work in Saskatchewan, in Regina, Saskatchewan, in acute care hospital. And the article is entitled Differences in Goals of Care Discussion Outcomes Among Healthcare Professionals, an Observational Cross-Sectional Study, and that was published in Palliative Medicine a few weeks ago. So the background here is that goals of care discussions are important, and that physicians and medical residents are often considered the default group to engage in these discussions. But there have been recent studies that have recognized the opportunity for nurses and allied health professionals to also facilitate these discussions. And in fact, they make the point that nurses have a strong therapeutic relationship with patients often and are in a unique position to contribute to those discussions. And in fact, in their paper, they're actually refer to some studies that show the benefits and impact of nurses initiating these discussions. So the objective of this study was to compare the outcomes of goal of care discussions led by nurses and physicians. But this is specifically on CPR, so cardiopulmonary resuscitation, and they acknowledge that goals of care discussions are far broader than CPR. And I think we can even just say that CPR is basically a consent to a certain treatment, or a DNR is a consent to no treatment, and it's just and emanates from the goals of care discussions. Anyway, so the setting, as I said, was a hospital in Regina. And the normal practice, interestingly, in the hospital there is that nurses, and that's the registered nurses and also the licensed practical nurses or registered practical nurses, as they're referred to in some of the other provinces. So RNs and LPNs are trained to initiate and establish patients' goals of care independently. And it's a responsibility that's shared with physicians. They don't go into any detail about what their training looks like. It was a retrospective cohort study of patients admitted to one of the internal medicine units in the hospital. And these were patients admitted over about a year and a half. There were 200 patient charts in total. And they then did a chart review on random samples of patients. And they looked at patients' decision to accept or refuse CPR was recorded and then analyzed. Now, they stratified the patients based on the basis of two instruments, the Charlson Comorbidity Index and the National Early Warning Score 2. So basically, these scores allow you to give an indication of the severity of the disease and the extent of illness of the patient. The higher the scores, the more comorbidity, the sicker the patients are. They did exclude patients that had been admitted already with established code status. Code status undertaken and documented prior to admission. So the results, so 52% of the charts or the discussions were completed by nurses and 48 were by physicians. And there were no significant differences between the cohort assessed by nurses versus the cohort assessed by the physicians. And what they found was that patients were more likely to accept cardiopulmonary resuscitation in nurse-led discussions compared to physician-led ones. And nurse-led 80.8% versus 61.4% with the physicians. When they looked at the Charlson Comorbidity Index, they found that for patients with a mild to moderate index, so low extent or low amount of disease, as it were, there was no difference between the nurse and the physician-led discussions. But when they looked at the severe category, the ones with high Charlson Comorbidity indices, there was a significant difference again, with patients more likely to accept CPR after nurse-led discussions than physician-led discussions. And then similar results as well when they looked at the National Early Warning Score. Again, patients more likely to accept CPR after nurse-led discussions when there were high National Early Warning Score levels. So, next please. Strengths, unique study, I thought, relatively simple research design. And as I said earlier, no significant differences between the physician and the nurse cohorts. The limitations was that it is a retrospective study, therefore they couldn't look at causation. They also did not look at the quality of the discussions that occurred. This is simply, did the patient accept CPR or not? And they didn't look at the quality of those discussions. And again, they make the point that this might not be generalizable, as this is one unit in a hospital, and may be unique in that the nurses are trained to do these discussions as well. And I want to end off my summary with the conclusion by the authors. And to quote them, they wrote, "Nurses and non-physician healthcare professionals are key participants in the goals of care discussion process, and further education is needed to empower all individuals to lead effective goals of care discussions." So with that, I'll open up for the discussion.
So I thank you for ending with kind of the summary, José, because I had more questions than I did answers as I read through this study, thinking about, but I have had in my career a very specific kind of community population of individuals, and it actually, in having goals of care discussion, often it appeared the opposite. But I'm palliative specific, that the sicker patients were often the ones who had clearer decision making in regards to that goals of care. And I don't know if they had the lived experience that went with that they'd had, multiple treatments or exacerbations of their disease, if that somehow changed. So I kept finding myself wondering, were these people, because anybody with goals of care discussion was excluded from the study, so were they arriving there with acute events and not understanding kind of the seriousness of their illness? So I left feeling more curious than anything.
And the study didn't look into that at all. And those are very, very important questions, as you highlight.
There's a comment from another clinical nurse specialist from Calgary, Jan Vendale, in the chat. Very curious about the word accept regarding CPR choices. Wonder if the case was more a patient's insisting upon CPR with nursing-led discussions, favoring the authority physicians on this very specific aspect of goals of care discussions. Curious about your thoughts about that, Lisa.
Yeah, and that's what I wondered. Is it the physician who still holds that kind of power decision making for that? Yeah, there are no more treatments that can be offered at this point. We can focus on, like, is there some validation that has to happen before the playing field is kind of equal per se? But it did, I did find myself circling back. If this is going to be a shared kind of process, then how do we ensure that we have the same tools to be able to equally have that discussion regardless of the hat that we're wearing, whether it's nursing or physician?
Yeah, and I'll jump in because I think this refers back to another comment Jan made earlier in our first discussion about ACP, was that how do we see the role of serious illness training fitting into advanced care planning goals of care conversations? And I would say, as again, like we're talking, having a standardized tool that we can train the whole team on to use in a systematic way enables everyone to be able to deliver better care. But I think, you know, we have triggers for changes in phase of illness or symptom screening that trigger these conversations, but then people have a tool they can use, just like dignity therapy for specific things, that is standardized and also teaches us how to document and communicate, because that's the other piece, right? So we can have these great conversations, but if we're not documenting them and communicating them within the team in a way that there's no gaps in care and transitions in care are complete, then it's a problem as well. So I think that's one of the benefits of the serious illness tool, and anyone on the team can be trained to use it, including social workers and spiritual care and even volunteers.
José, I feel very strongly that that these discussions, that's advanced care planning or goals of care discussions, should not be the monopoly only of physicians or medical residents or students. Quite the contrary, I think it is whoever it is that makes a connection with the patient or is in that particular moment the best arriving at the situation to do that. And I wonder whether it'd be interesting to do a study across the country as to what are the attitudes of healthcare professionals in different settings. And this one looked at hospitals, right? A hospital internal medicine unit. But I'm wondering in other settings, what are the attitudes of different professionals towards who is or who should initiate these discussions? Because I think that we're going to come across a lot of barriers about that. And so I think a lot of work needs to happen to explore that, understand that more, and then, as you'll say, is to equip everyone with these skills and tools, and so that we can all be doing a good job with it, and that we collaborate when doing it. And sometimes I'm sure you've all had experience where someone goes in and gets the ball rolling, and then someone else follows up and follows up on those earlier discussions, and it becomes a process rather than this one event.
Yeah, exactly. And I think one thing, sorry, Jordan, one thing when I was in Alberta that they did very well there was they have a living tracking record. So anyone can enter the conversations that you have with a patient into the tracking record, because that's actually a limitation in many EMRs, is not many of the interprofessional team members can necessarily enter into the health record. So how are you going to encourage them to be playing a role in the team and doing that if they're not able to document? So having a living tracking record that everyone can communicate in and keep that conversation that changes over time a living document is really critical.
And I'd also say, just in terms of also just systemic, also like EMR specific things, like many times, like to change somebody's code status officially, it's an order that has to be put in by a physician. So, can we look at systemic things within our healthcare system that are, like José was saying, are barriers? Because I think nurses are fantastic resources that, again, in many healthcare settings, as palliative care physicians, I think we often, have the luxury of spending sometimes more time with patients and getting to know them in that holistic sense. But many doctors don't, and many times it's the nurse who really knows the patient's, things that are the most important to them, their values and preferences, often, because of that, being at the bedside and knowing them and their families. So I think they are a potential underutilized resource that I think we're going to see more and more as just in general nursing scope of practice is broadening.
Very much so. And perhaps we're going to end off that discussion with a fantastic quote here, or comment from Melissa Bonner. As a registered nurse, I have also been trained to initiate goals of care conversations. I have this conversation at least annually with all my residents, and that's in continuing care. So a fantastic comment to highlight the importance of this in another setting that we often don't talk about, continuing care.
Okay.
You.
Yes, we'll move on to our last article. So this one is from the latest issue of Palliative Medicine, and I have a small typo on my slide here. The first author is actually Mira Agar. So Mira Agar and colleagues from May 2022, and the title of the article is Investigating the Benefits and Harms of Hypodermoclysis of Patients in Palliative Care, a Consecutive Cohort Study. So I think just briefly by background, we all know that hypodermoclysis is commonly used in palliative care to provide hydration and symptom benefits while reducing the need for intravenous fluids. But really current research is, it's lacking. We've got a lot of older research and has been inconclusive and somewhat contradictory in its recommendations for using hypodermoclysis. Some studies suggest that there's no symptom or survival benefit at all, and other studies suggest specific benefits such as maintaining cognitive function or reversing delirium, for example. So the objectives of this study was to prospectively identify the benefits and harms of hypodermoclysis in palliative care patients with advanced disease where it was clinically decided that they required supplementary fluids. So the clinician decided. It was a multi-site, multinational, consecutive cohort study for patients newly receiving hypodermoclysis in an inpatient palliative care setting across 20 sites in Australia, Canada, Germany, Malaysia, and the UK. They used a case report form to collect the data in the REDCap system using a predefined set of clinical symptoms that were related to known or potential benefits and harms of using hypodermoclysis. So they captured specific benefits, including fatigue, dry mouth, generalized weakness, dizziness, delirium, and vomiting. And specific harm categories included edema, urinary frequency retention, ascites, pulmonary edema, infusion site reaction, capillary leak syndrome, and dyspnea. They then looked at the severity of harms using a National Cancer Institute common terminology criteria for adverse events, Likert scale, and that was assessed by the treating physician. They collected the data at the baseline, so time 0 was the time of the primary assessment by the clinician, and 24 hours later, which was time 1, 24 hours post-infusion of the subcutaneous fluids. And they captured a change of a score in at least 1 point, to be considered clinically significant improvement in symptoms. They ended up collecting data for 99 patients, but only 88 of those had the full assessments for benefits and harms collected. And they also captured additional patient characteristics for the cohort using demographics, clinical data, comorbidities, and performance status using the Australian modified Karnofsky performance scale and phase of illness, which we talked about earlier. So in terms of results, and there's quite a lot of information in this study, but I'll just highlight a few things. So they actually, just because you might ask, the mean infusion rate was 935 mils of normal saline over a 24-hour period with, so the median was about 40 mils an hour with a range of 20 to 60 mils per hour. The most common primary indication for hypodermoclysis was supplemental hydration, about 32%, followed by about 30% specifically for family request. Of those who were designated as the primary indication for family request, there was no target primary symptom identified in a third of those, and then another third had generalized weakness noted as the target symptom. So overall benefits in a primary target symptom were experienced in about 33% of the cohort. And when they took into account any target symptom, it was just over half. About 10% of the cohort experienced symptom resolution, but they didn't look at which specific symptoms had a higher degree of improvement than others. Harms occurred in almost 39% of participants, and it was predominantly lower extremity edema. And more frequent harms and less benefits were seen in those in their terminal phase of their illness, as defined by the Karnofsky performance scale of 10 to 30%, and a phase of illness in their deteriorating phase. In that setting, harms were 46%. And in terms of benefits in those folks at the end of life, it was 0% for the primary target symptom and 15% for any indication. So why is this article important? Well, I think we said earlier, there's not a lot of very good evidence base for our use of hypodermoclysis, but it's very commonly used. We know that it may improve certain symptoms in patients, palliative care, but we don't really know the frequency of harms and benefits. And, certainly the study contributes to the literature in terms of there's less benefit closer to the end of life, but really need more information around are there specific symptoms that could be targeted with a better evidence base. And really, I think the implications are that careful individual assessment as we do is needed for considering hypodermoclysis and making sure that we have good family discussions about the potential benefits and harms, especially given a large number of the indications for using hypodermoclysis in the study were family request. Future research, carefully designed research trials are required. This is the author's suggestion, which should consider performance status and predictions of life expectancy when evaluating the potential benefits of hypodermoclysis. And as I just mentioned, which symptoms can be specifically improved with hypodermoclysis. Some of the strengths, it was a prospective study from multiple sites in multiple countries, provides kind of a real world view of hypodermoclysis and its indications and minimized their selection bias by their methodology. But of course, limitations are that the majority of patients had malignant conditions, which can limit the generalizability. Out of the 20 sites, 14 of them, so 70% of them were actually from Australia. So limits the understanding of variation of practice by country. And we don't know how countries who weren't part of the study do things. And then I didn't focus on this earlier, but the short time frame. So we, time 0 to time 1 was 24 hours. So you capture the more immediate effects of hypodermoclysis in terms of its benefits and potential harms, but not the longer term when we know many patients are on it for many days for ongoing infusion. So those are some of the highlights. I'm curious to see what others thought about this article.
I'll jump in. I thought it was certainly an interesting article. Again, I think it confirms some of the what we often at least say to patients, especially in the terminal stage. So in somebody's PPS 10-20%. I think it certainly confirms that the teaching that we often do that at that stage of periods of times harms vastly outweigh the benefits. I think it was interesting in terms of I think there are some patients who might benefit from this, but it was interesting that in terms of the indications, I think almost like 2/3 of it was either at family request or supplemental hydration, which it's not really a symptom either. And when you look actually through the study, the top 3 primary symptoms that they were targeting, I believe, were fatigue, generalized weakness, and dry mouth. And when you look into the chart, when you look through actually all of those symptoms, each one of them, people have a benefit in less than 25% of those cases, and harms are about 30 to 35%. Albeit, most of those harms tend to be things like lower extremity edema, which depending on kind of how people feel about that. So I think that for me, it kind of indicates that I think it's not unreasonable to try something, but I would do a time limited trial, and if I'm not seeing the benefit, then I'd be pretty quick to kind of stop those things. Because again, as the paper also says, they didn't really measure harms after a prolonged period of times. And I think it's unlikely that if you're not seeing a lot of benefit within a fairly short period of window, you extend or increase the risk of those harms on an ongoing basis.
Leonie, could you explain us again just how they determined whether the hydration was worsening, things like edema? And I ask this question because at the end of life, often we'll see the peripheral edema, not because of the hydration, but because of low albumin levels caused by the advanced disease or obstruction in the by lymph nodes in the pelvis.
Right. Yeah. So, I mean, the difference between time 0 and time 1. So in that 24-hour period, so they did the baseline assessments using those NCI scales that I mentioned that looked at, and then they reevaluated those 24 hours later. So again, it's a very short window, but something they assumed the change was because of the intervention. But again, that's not conclusive, of course.
Yeah.
In this study, Leona didn't take in like our cardiac patients either, did it? So we don't have that evidence to suggest kind of, I go back to Jordan's, it's really a case by case basis. And I love that you've mentioned that therapeutic trial, that we have a start time and an end time, and then we're going to evaluate the harms and the risks and decide, has this provided benefit? Absolutely essential.
Fantastic. And I see we've reached the end of our session. Very quickly, let's list the honorable mentions. So again, a broad variety of papers. There's the topic of hope, the topic of managing nausea, factors related to the quality of end-of-life care in patients with interstitial lung disease. There's a systematic, there's a look at palliative systemic therapy given near the end of life for metastatic non-small cell lung cancer. There's evaluation of an interesting one on the efficacy and safety of subcutaneous acetaminophen, among others. So we would really ask you to have a look at our website. The presentation will be posted on the website as along with the recording actually very soon. Let me take this opportunity to thank again Leonie, my partner on this with this podcast, and to a fantastic panel today with Lisa and Jordan as our guests. Thank you for taking the time to be with us and share your insights. And again, we hope to see you in the next session, which will be September the 26th of this year. And I'd also like to take a few seconds to thank the teams that monitor all these different journals. And these are teams, as I said, across different sites linked to our divisions of palliative care at Queen's and at McMaster. Thanks for joining, everyone, and hope to see you soon again. Bye-bye.